This is about cervical shortening for part 3 MRCOG, a quick revision. Okay, the scenario is 24-year-old Indian, 18 weeks. Her GP referred her and her ultrasound at 16 weeks showing cervical length of 3.3 centimeter and 17 weeks 6 day her cervical length is 2 centimeter. Her urine routine is normal. So how we will proceed with the station? First of all, we introduce. I'm Dr. ST5 in the clinic today. I can see, are you comfortable with English? And do you want any interpreter? Then may I confirm your name and age, please? What would you like me to address you? I understand from your GP letter that you are 18 weeks in your first pregnancy, and you're here to discuss a scan report. Is that right? Do you have any concerns or expectations from today's meeting? I'm here to help you and address all your concerns. Prior to that, is it okay if I ask you a few questions so that I can know more about you? Now coming to the questions. How was your pregnancy so far? About tests, down screening, and are you taking folic acid regularly? About the booking scan, and do you have any abdominal pain, any vomiting, any bleeding or leaking, any discharge of fever, any bowel or water work complaints? Then what about your previous pregnancies? So she will tell, mostly in this case she will tell, I had a previous pregnancy which was preterm early delivery. Then we have to we can ask, I'm so sorry to hear that. How was your baby doing? Was it a spontaneous vaginal delivery? Was anything told about what was the cause for that? Like that we can ask. Then about any history of any sexually transmitted infection or not. Then routine history, medical, surgical here important. We need to ask whether there was any surgery to your tummy or lower down to the neck of the womb. Specifically we can ask that. Then family history we can ask, any allergies, any other medications, and about her weight to height ratio, blood group, any reservation for blood transfusion, her support at home, is she safe at home, and also specifically in this case we can ask whether there is any history of abuse. That is important. Abuse history we need to ask here. And about her mental health, do you feel any sort of low down depression in the recent past? And we can tell her, ask her personal, may I ask you some personal history, do you smoke, use alcohol, any recreation drugs? And we can thank her for giving all this information. And may I examine you in the presence of a chaperone with your consent. I will be doing a speculum examination to know whether there is any bulging of the membrane. I will be gentle in my examination. If you feel any discomfort or pain, I can stop at any time. Okay, so we give a reassurance and we are telling that. Now coming to the ultrasound, we can say, now I'm going to explain you about your scan report. I have confirmed your name with the NHS number. This is in fact your scan. Do you want anyone else to be with you while discussing the report? Okay, I'm giving you some concerning news that the scan is showing that we can draw and show her. This is a womb, this is the neck of the womb, and this neck of the womb is supporting the pregnancy. So in your scan I can see that the neck of the womb has opened up and shortened. So I'm afraid sometimes this can lead to early labor as like you had previously. I'm sorry to be giving you this news. So she will be asking, why doctor, why this happening to me? So we can say there may not be any particular reason. We couldn't find any reason from your previous pregnancy as well as from this pregnancy. Sometimes it can happen like that even without any reason, that we can say. Then is it okay if I discuss you about the management options? Now coming to the management options. One is the surgical option of cervical circlage. That how we have to explain is, the first option is the cervical circlage, and second option is using hormone progesterone. Third option is putting some vaginal pessary. I will be discussing you about each one in detail. So coming to the cervical circlage, it is done from the it is surgical option done from the OT by under spinal or general anesthesia. That we have to explain is by numbing from down waist down below, in general anesthesia by putting you in sleep. Then then we are putting some stitches through the vagina to tighten the neck of the womb. And it is a straightforward procedure, but like all other procedure, there can be some sort of bleeding, leaking, sometimes the injury to the bladder, water bag, or sometimes injury to the neck of the womb. and sometimes it may not be able to put, we may not be able to put the stitch. Sometimes the neck of the womb may be too short or open up, and however I must tell you that sometimes we may not be able, even if you put the stitch, we may not be able to prevent the early labor. I'm sorry to tell these things. Minimal spotting or brownish discharge, but it can be self-limiting. Sometimes after recovery you can resume to your normal work. It is not recommended to have a complete bed rest, and also you can resume to your sexual activity if you are comfortable to do that. Okay, then if you want, when we have to tell her when she has to come back. If there is bleeding, pain or leaking, in such cases she can come back immediately. 24-hour contact number also we can provide her. Then when we also the plan for removal, that is by 37 to 38 weeks, and no anesthesia is required. Just by putting a speculum we can remove the stitch. And sometimes in cases where there is pain early, or if there is leaking, in that cases we may have to remove the stitches early. Then coming to the second option, progesterone, that is we are giving it from 16 to 34 weeks vaginally, and it is safe for pregnancy, safe for baby. And also we should emphasize that there is no need to, if there is a cervical stitch, additional progesterone not needed, not recommended. Then the third option coming is pessary, that is putting a ring-like structure inside, Arabian pessary. It hold up the cervix and prevent it from opening, and the advantage is that it is quick and easy. We need to take a swab prior to this procedure, and sometimes there can be discharge, and the subsequent ultrasound monitoring may be difficult, and there are limited evidence regarding this. Okay, so that's all about the options. Now we can ask her, what do you think about these options? So if she's telling she wants some more time for deciding, we can tell her you can decide. If you want, we can discuss with your partner as well, if you wish, and we can provide her the written information leaflet. We will tell her that we will be documenting. We'll write back to the GP about the. We can tell her that I can understand that you're going through a difficult time. We are having counselors and support group facilities. If you wish, we can connect you with that as well, and if you want, we can book an appointment with our consultant as well. And do you have any other questions? Thank you for your time.